bi-weekly podcast focused on functional neurorehab. Before we begin, a reminder that this episode is available for 0.1 ASHA CEU. If you are joining us on a podcast platform and would like to earn ASHA CEUs, please complete all course modules of this episode on your SpeechTherapyPD account. Participants can ask questions in the chat box, and we will answer those at the end of the session. We will end the conversation on the hour. So if you do need to leave, please stay until the end of the hour, and then we can include some questions after. All right, Renee. Oh, sorry. Let me do the disclosures first. Okay, here are the disclosures. Mary Beth Hines, the host of Keys for SLPs podcast, receives compensation from SpeechTherapyPD. She is employed by Life Speech Pathology and the nonprofit Voices for Parkinson's. Renee Garrett is the owner, founder of BrainBridge Connect. She receives financial compensation from SpeechTherapyPD for hosting podcasts and other educational webinars. Dr. Hallowell is the author of a book with content highly related to this podcast, Aphasia and Other Acquired Neurogenic Language Disorders, A Guide for Clinical Excellence. She receives royalties from the sale of that book. Dr. Hallowell is a member of the Board of Directors for Aphasia Access, Director of Research for Aphasia Recovery Connection, and a member of the Professional Advisory Council for the National Aphasia Association. Dr. Kiran is a co-founder and advisor to Constant Therapy and owns stock in the company. She is a board member of Aphasia Academy, board member of the American Speech, Language, and Hearing Foundation, board member of the National Aphasia Association, advisory council member of the National Institutes of Deafness and Other Communication Disorders.
Hi, welcome everyone. Dr. Brooke Hallowell PhD, CCC-SLP, ASHA Fellow and Honors, is president of Brain Empowerment, LLC, a global clinical consulting and research entity fostering empowering approaches to aphasia and other communication challenges. She also serves as Director of Research for Aphasia Recovery Connection, consulting editor for Plural Publishing, a member of the Board of Directors for Aphasia Access, a member of the Professional Advisory Council for the National Aphasia Association, a representative to the World Health Organization, WHO's World Rehabilitation Alliance, and an active WHO consultant. She formerly served as Dean and Professor at Springfield College, Professor at Ohio University, and President of the Council of Academic Programs in Communication Sciences and Disorders. As Mary Beth mentioned, she's the author of Aphasia and Other Acquired Neurogenic Language Disorders, A Guide for Clinical Excellence, second edition from Plural Publishing, 14 books published by the National Science Foundation, and numerous articles and book chapters. Welcome also to Dr. Swathi Kiran, PhD, CCC-SLP, ASHA Fellow and ASHA Honors, who is the James and Cecilia Ying Professor of Neurorehabilitation in the Department of Speech and Hearing Sciences and the founding director for the Center for Brain Recovery at Boston University. The mission of the Center for Brain Recovery is to study neurological disorders in the brain while focusing on real outcomes for the patient. She has over 180 peer-reviewed papers in these fields and has been funded by both NIH and the ASH Foundation. She currently serves on the NIDCD Advisory Council. She's the past board chair for the Academy of Aphasia, board member for the National Aphasia Association, and the American Speech Language Hearing Foundation. She is the co-founder and scientific advisor for Constant Therapy Health, a software platform for rehabilitation tools after brain injury. Thank you both so much for being with us today.
Thank you for being here. We're so excited to have you both.
It's wonderful to get to join you today. Thank you.
Well, it truly is our honor to have both of you with us. So before we dive into our topic today, can you tell us something fun about yourself that many people may not know?
I could tell. I had a couple of other careers before I came into this one. One of them was as a French horn player, and another one was as a French teacher.
It's so fun.
And a lot of people know that I study bilingualism and multilingualism in people with post-stroke aphasia, but my interest really comes from the fact that I speak 5 languages, and I grew up as a child in Africa before I actually moved to back to India, where I got my early education.
That's amazing, 5 languages. And at what age did you acquire your 5th language?
Actually, I acquired 3 of them as an adult at 11 years of age because I moved back to India when I was 11, and I did not speak any of the Indian languages at that point. So I learned Hindi, Tamil, Telugu, Kannada all at the same time. And actually, I learned Kannada when I was 18. And I'm a good example of how practice makes you actually fluent and proficient in a language. I'm sure Brooke agrees with that because you probably learned a lot of languages in your adult life as well.
Well, thank you for
so
sharing.
true.
All right, Renee, let's take it away. Let's dive in.
All right. So, Dr. Hallowell, what can you share about your journey that led you to speech pathology? I always love to start my podcast with talking about people's why and just what led you to this. You mentioned, you had a different career prior to. I did as well. And so I find it interesting how we got to this field because it's still, to me, not really well known. A lot of people are assuming, I'm sitting on the floor with little kids teaching them how to say their R's. So, what led you to this career?
I think there was just so many different things that came together. It wasn't one thing. Early in my life and through my childhood, my mother was an activities director in a nursing home. And I used to spend a lot of time there with her and just hanging out with the residents. So I had a real comfort around people with disabilities and a real comfort around people with communication challenges. Another thing about my early childhood is that I had selective mutism, which is, as many of our listeners probably know, an inability of a child to talk in certain contexts. And it's really a misnomer because kids don't choose not to talk. They don't select not to talk in certain situations. They really can't. But that idea that you have something to say, that you're linguistically fine, you understand everything, you're intellectually fine, but you just cannot communicate and connect with other people through language is something that I think it stays in you long after the bulk of the recovery process. So there's that just sense of I know a sense of just I know what that feels like. Yeah, I grew up in a home that we had a lot of international visitors. My parents were very engaged internationally, so I had a lot of interest in languages. And when I went to university, I was studying about psychology of language, neurology of language, cognitive science, and I had an amazing mentor, Sheila Bloomstein, who really, it was incredible to have her, be exposed to her and have her as a mentor at such a young age. And that was really got me so curious and fascinated in how language is processed in the brain. So I was really interested too in learning about research on aphasia and language processing in the brain. I kept thinking there must be more to it. There must be something we can do to help people who have these challenges, not just study it. And that's what led me to look into a clinical area of research and practice.
Wow. And Dr. Kiran, how about you? What led you to your career in speech language pathology?
Mine was actually more straightforward. I think when I was in high school, I really wanted to study neurology and be a neurosurgeon. And I was just always fascinated with how the brain dreams, and when we sleep, do we dream thinking in language or is it just thought? And are there no words in our dreams? And we all have different kinds of dreams. I was really fascinated about that. But when I decided to start studying the brain, which I was always fascinated with, even in school, I decided that I wanted to study something like dreams, but when things went wrong. So I found out that aphasia was actually a topic where you could study what goes wrong in the brain. And because I wanted to stay connected to the dreams, language seemed like a good thing to study. So I came to Northwestern University to do my master's and PhD with Dr. Cynthia Thompson, and she was studying language in post-stroke aphasia at that point, and I just knew that's what I wanted to do, wanted to study.
Well, and that's really also very interesting because I think it's people's paths are so different, but yet intersect in ways that we don't often see coming. And you mentioned your role into aphasia, so that kind of leads me to my next question about how the treatment and evaluation of neurogenic communication disorders has evolved through the years. And I know even for me, I'm only 15 years in the field because this is my second career, but I've seen a lot of changes in the way that we do things, starting kind of with life participation approach and other methods and techniques. So, Dr. Kiran, what would you say kind of led you down that path? And what have you seen
So
change?
I think that, as you said, the field has really changed quite a bit. When I came to do my master's back in 1995, I remember having conversations with my doctoral advisor, Dr. Thompson, about whether treatment even worked. In fact, most conferences that we would go to, we would present these single subject data, 5 participants, 7 participants, and show that in every individual, you start at a baseline, you do some therapy, it works, and you're saying, hey, these patients are getting better. And most of the times, depending on which conference we went to, we were just trying to convince people that therapy was helping, that these brains were changing, even though the patient was 10 years post-stroke. We were showing these curves that patients were improving with time. I'm so happy that today that's not a question anymore. Everybody sort of agrees now that the brain is plastic several years after their stroke, and therapy helps. So that's a huge change from 30 years ago, where you had to even convince people that the brain that progress doesn't plateau. The other thing, the other two things, and I know Brooke will talk about one of them a lot more, but the other two things that have happened over this course of time is really strong evidence suggesting that you can change the brain through neurostimulation or brain-computer interface or certain kinds of treatments that actually help catalyze brain plasticity. So that's actually another thing that's changed, is we understand how the brain can be plastic. And the other piece is we have come back to thinking about the patient as a full person, not just a bunch of problems, but really how do we treat the person as a whole? So I'll lead into Brooke for that part.
Yeah, I couldn't agree more. Just well said, Swathi. And yeah, I think part of that recognition of the power of neuroplasticity also links to a sense of empowerment of people at any age and at any stage of recovery. I think, when in early days it was people were told, in fact, and sadly, some people are still told that they will just reach a plateau or they will only get better in the next 6 months or the next year. But I think we've all switched, those of us in the professional world have largely switched to thinking about the chronicity of aphasia, the lifelong consequences. And related to that, the notion of identity and emotional and mental health and health of the family. And these are all things that are much more embraced holistically about the life consequences of aphasia rather than just looking at the aphasia itself. We've changed really in the models of what we think of as disability in general. So aphasia fits into that. If we think about the World Health Organization International Classification of Functioning and Disability, we've really worked to think about more holistically about what are the challenges in a person's life and what should we be doing, not only about the aphasia itself in terms of deficits, linguistic deficits, but what should we be doing in terms of support, in terms of participating in daily activities, in terms of the kinds of environmental changes that have to happen. Yeah, and again, that focus on identity. So with that comes also the role of counseling in our field. So many of us didn't get really much training in counseling, and now there's more and more interest in embracing counseling, and attention to mental health is fundamental to speech language pathology scope of practice.
It's almost like you were in my head because that was something I was going to comment on, was how a lot of the work early on wasn't centered around our role as counselors and wasn't centered on caregiving. But my experience was caregiver first before I was an SLP. And so I think that's such a crucial part of what we do. So thank you for mentioning that.
Mm.
Now we're so thankfully involved in a life participation approach. It's even hard to think 30 years ago how it was. We had that 6-month plateau, and that was it. And we really didn't engage in the life participation. So lots of positive changes, physically, cognitively, mentally, surrounding aphasia. And along those lines, what research, and we only have, an hour for this podcast. So it's a big question, I understand. But what research do you find was pivotal during your career as a speech language pathologist in the area of neurogenic communication disorders?
I can start and see where we go with that. Again, most of my research has, and my professional environment has focused on the neurological aspects of aphasia. And I would say that the key things that have happened, the key sets of findings I think that have happened over the years, is that, first of all, I'm going to repeat again that this myth of a 6-month recovery and then a plateau has been busted. As far as we can tell, people now understand that recovery is lifelong, and it's not just the person, it's the entire social milieu that they're involved in. We've also really, with the help of brain imaging techniques, understood which parts of the brain are really crucial for language and how recovery happens over time. And we really have a lot of neuroscientists to thank for their collective work looking at brain imaging and aspects of recovery. And so the way that I would summarize this to a layperson is, it turns out that the real estate of the brain, both the hardware, which is what parts of the brain are not damaged or sort of remaining, and the software, how the hardware connects and communicates, is really important for that recovery. And whether you're learning to speak words again or whether you're enjoying the opera, that synchrony of your brain regions really kicks in, and helps with that lifelong recovery process. So that's a second piece of research that's really changed our understanding. A third piece of research that is still ongoing, and it's very exciting, is brain stimulation. There's lots of really good research that has been done that has shown that when you stimulate parts of the brain using these very novel techniques called either transcranial direct stimulation or transcranial magnetic stimulation, what you're doing is you're lowering the brain's responsivity to therapy. So the therapy doesn't go away. You really need the therapy in these brain stimulation studies, but it helps the brain learn. It primes the brain to learn and recover. And this has been a huge game changer for our understanding of helping patients with aphasia, that is only going to get better in the next 10, 15 years. Another thing that's really emerging now, and you see commercial companies like Neuralink that are looking at putting electrodes in the brain and decoding how the brain thinks and how language is processed. This is also going to be very exciting, because so far they've been only able to help people who have no damage to language areas, like people who have ALS, but at some point they're going to figure out how to do this in stroke regions as well. So that's going to be quite amazing as well. And then lastly, I think we understand the effect of therapy quite a bit, and I'm happy to be part of that work as well, where the kind of therapy we're doing, whether it's word practice or it's going to the opera or Toastmasters, you just need practice. You need a lot of that practice for the brain to change the way it can rewire. And this notion of providing intensive therapy, like every other muscle you exercise, I think has really set in for people who are trying to understand aphasia. So those are my 5 big points. There's so many others, but we can come back to that.
Yeah.
Thank you for sharing. And Dr.
Yeah.
Hallowell, how about you?
Oh, I just concur completely with all the things that Swathi mentioned and appreciate her contributions to those areas as well. And I would just add to that, since she's here, that a really important contribution she's been part of is looking at complexity. We don't just need to start with easy things, but that actually challenging ourselves with what we're working on can really be helpful, and that sometimes working on really difficult things actually has more of an impact than just going from easy to difficult, which is not how a lot of us learned about doing therapy. So I love that about her contributions. Overall, in addition to what she's shared, I'd say we are really growing now in implementation science. So many studies in the past were done and they were sort of encapsulated in research studies, and people often, if they looked at carryover, it might have been 3 months, 6 months later, but now we're really looking at what difference does it make in people's lives? In whose opinion does it make a difference? In what specific ways? What are different ways of assessing those outcomes? So, we're heightening our focus on the translation of the research we do. It's no longer acceptable just to publish work that's read by other people doing the same kind of work, but really what's important about what we're doing, and holding each other accountable to that we're really making contributions that affect people's lives. That we have a long way to go in implementation science, and other fields are well ahead of us, but we have some great leaders emerging in that area, and I'm excited about that. Also, we've really blossomed with research co-design, including people with aphasia in designing research studies and helping define what's important. Also, in having people from varied disciplines involved, so interprofessional education, practice, research is really important. Much more focus on multidisciplinary teams engaging in research, and I think that's really enriched our field as well as other fields as well. And that with that comes more collaborative research. So rather than, a lot of times research has been traditionally siloed in different labs within different universities or even within countries. And within languages. But now we're just opening up into a much more internationalized global community of scholars. And we have more international groups collaborating, much greater numbers of people collaborating together and bringing in expertise across languages and cultures. So that's a really exciting development.
It is. It's an exciting time for our field. And back to what Dr. Kiran said about TMS and TCDS, do you envision that those therapies being part of or being used in conjunction with speech therapy as a regular practice within the next few years, 5 years, 10 years? What would your, and not what your hope is, what is your expectation?
So that's a great question. It's a little hard to forecast, but TDCS has been approved by FDA for depression. So that's actually the only indication that it's been approved for. So it is possible, as more and more clinical trials show the benefit of the combination of TDCS plus therapy, that it might be something that neurologists, physicians, doctors, speech pathologists can do this in their clinic as routine clinical care. So there's two things I think that are going to hasten the work in this area, because the clinical evidence is already showing that it is pretty effective. Again, I think the thing that I want to say is very important, especially for this audience, is when people started studying TDCS, they were just looking at, does brain stimulation help recovery? And it turned out it was not enough to help recovery. It was really the combination of brain stimulation paired with speech therapy that was really helping the recovery. That therapy was super important for that recovery to really help the brain recover. So I can see the TDCS as an adjuvant to therapy, not the other way around in the future. So as we're getting better data, what I think will happen, what needs to happen is we really need to be able to personalize where the brain stimulation is, because every patient has ends up with a stroke in a different part of the brain. And there are lots of people trying to study how do you personalize that stimulation. So we need progress there. We need progress on personalizing the dose of the therapy and the stimulation. For some people, they may need more. For some people, they may not need as much. So I think that's the other piece, because one size definitely does not fit all. And then the third part is the access. So if everybody has to come into a clinician's office and get the stimulation and therapy, I don't know how effective it will be. And again, there's innovations in creating easier versions that you could just mail to the patient's house and have them try to try to do this at home under guidance. So there's innovations coming. To what extent they're successful will determine how quickly it gets adopted.
And early on, have you seen a lot of differences between the TMS and the TCDS?
In terms of outcomes?
In terms of outcomes. I know the transcranial magnetic stimulation, that requires you definitely to go into an office. It's a lot of machinery. It's not going to be accessible. But as far as it being more effective than the direct stimulation or less effective, has there been?
I think yes, so I don't think anybody has directly compared those two to each other, but overall there's a lot more scientific evidence around the transcranial direct stimulation. There's some very large clinical trials. The biggest is by Dr. Julius Frederickson, excellent study, and they're continuing to do fine-tuning that approach. So I would say the bulk of evidence is stronger for transcranial direct stimulation, but it's also going to be the one that's easier to do at home if it gets to that point. Just recently we had one of the main people who develops the transcranial direct stimulation technology show us how it can almost be like a Band-Aid that you can apply on your head. So I think that's going to make a big difference because it's going to be a lot more accessible.
That's exciting to think. Yeah, thank you for sharing. Okay, so besides brain stimulation research, what other research, if you could make a wish, what other research would you hope to see in this field? And Dr. Hallowell, do you want to answer first?
Well, I would just continue that. I mean, we are also just seeing great gains in brain-computer interface. So I think there's great hope there in terms of extended related technologies too, especially for people with aphasia. Having spent a couple of decades developing eye tracking methods to study cognitive and linguistic processing in people with aphasia, I would just say that we can capture things that just can't be captured by behavioral assessments that require conscious movement, intentional movement, and spoken language or written language. In people with aphasia, we underestimate, I think, a lot what people are capable of doing given the behavioral methods we use so typically in assessment. So just seeing the gains we've made and what we can capture through eye tracking, I can only imagine what gains we're going to capture when we have more solid brain behavior interface technology. And also the technology is largely there in a lot of it's the access to it and it's the usability of it and the affordability and that are greater challenges. Yeah, but I'm excited about that. Again,
I was just going to, if I can jump onto that bit,
sure.
Brooke, I don't think it's science fiction to think that in another 5-10 years we could develop something that looks like, what you see in the Iron Man movies, where it's sort of trying to read his brain because you've got brain-computer interface that can record from the brain and decode what somebody's thinking or about to say, but you get that feedback in real time. You're looking at where the person's looking at, like what Brooke was saying, and give the person therapy in real time. And sometimes I tell my students, imagine if you could develop this technology where the person goes to Starbucks and in real time is getting the feedback and the cues and the support they need. Again, as Brooke says, the technology is there. How it all comes together to help the patient is sort of up to us there.
Oh, it is exciting. Anything else that you would like to add to your wish list, your research wish list?
Yeah,
One thing. Oh, sorry,
Go
go
ahead.
for it.
Go ahead.
I was going to go in the medical direction because there's some really exciting work that's been coming out, and this actually just got. There was an article in New York Times about this a week ago. But people are trying to develop ways to reverse the effects of brain damage after a stroke. So this is very, very new. It's still happening in animals, but but there's also work where people are developing brain organoids, or you're developing brain cells from these pluripotent stem cells. And if you could just figure, and the reason to do that work is you can actually grow the cells and then disrupt it and see what the mechanism is. So if there was any way for us to reverse the effects of the stroke, which people are doing, that could be huge, because then whatever the reversal of the stroke does not take care of, it would be really trying to reduce the disability, which is really what many of us are focused on doing. But there is hope there as well, that there's some of these advances in brain organoid work and in stem cell work that might actually make a big difference.
And Dr. Hallowell, how about you?
Well, I'm just mindful of our time here. One area that I'm really delving into personally is in the power of hypnosis in intervention with people with aphasia. And I think years ago when people studied this, there was sort of this notion, oh, hypnosis, that's some woo-woo stuff. But now we have so much more science behind the levels of consciousness and how people process information beyond just a level of awake awareness, and how important it is to support people in the changes they wish to make. So there's really interesting work happening in terms of both linguistic foci as well as communication anxiety that kind of confounds the severity of aphasia by first there's the deficits itself in a person's communication ability, but then there's all the emotional aspect around that and the challenge of stress and anxiety around communication. So I think there's great hope there, and I think we're in an era now where people don't see that as not mainstream or somehow people had these ideas decades ago, but it wasn't a time when this kind of research was accepted. And it probably helps that we have so much more scientific basis for what's behind that, so much more evidence for what goes on during different hypnotic states.
Fascinating. Well, all right. I think we could talk about the future all day, but Renee, do you want to take the next question? I know we are mindful of time.
Yeah, so I know we've talked about significant changes throughout both of your careers, but is there a particular theory other than like neuroplasticity and sort of the service delivery model of this time constrained space? What would you say is a theory that's been debunked by research that was maybe an kind of an old school theory that people thought worked? Dr. Hallowell?
Oh, I don't know if I'd call it a theory, but we have spent a lot of time historically pounding into the minds of future clinicians about the Boston classification of types of aphasia, and that we have these different, this is this and this is how a person is. And I think we've really come a long way in recognizing it's important to know those brain behavior relationships and types of aphasia, but it's also important to really look at the person and that person's constellation of symptoms when we think about type of aphasia, and that we also really tune in more to the evolution of a given person's condition. It's not just one thing that gets diagnosed and then it gets put on their record, and that's how their aphasia is, because people do evolve over time. Yeah.
Dr. Kiran, how about you?
No, I completely agree with that. In terms of being debunked, I think I wouldn't call it that, but I would say that I think all of us in the field have come to this acknowledgement that we really have to think about the person as a whole and in their social milieu. And so I'm optimistic that what all of us are trying to do right now is not just fixing the brain, but enabling the person to return to their environment and be successful. And whatever way we can do that, is a contribution to the field. So in the work that I do, of course, we work with the stroke survivor in terms of therapy, but we're also developing our brain imaging, our methodologies to understand what's going on in the real world setting. So our innovations in research and science is studying the patient at home using brain imaging methods because it's more of their real life, and trying to capture, trying to use AI and trying to use machine learning to understand disruptions in speech and language and prediction in the real world setting, not just in the lab or the clinic. I think everybody's there now. I think a lot of people are starting to say, let's get out of the clinic, let's get out of the lab and see what these people need in the real world setting and help them there.
Yeah, and early on in my career, I worked in inpatient rehab, and that was one of the things that we were still able to do with some limited access, but community outings with our patients prior to them transitioning to home, if they're able to get back home. But there was the movement away from that because of the constraints of insurance, unfortunately. And so I think more and more clinicians who are in private practices are doing that. They're going to the patient's job, they're meeting them at the coffee shop, they're going to a family, small family thing, and working with them to implement their strategies and make sure that they feel more confident and empowered so that they can see it's okay to make mistakes. We all do that. We all have missteps when we speak. We all have times where we're disfluent. And so I think us being able to say, hey, we're human too, we're not infallible, gives a good example for the patients on what's possible and what they can do.
Yeah. One thing I want to sort of add, and this is by no means something that's been debunked. It's really a struggle that not just speech pathologists, physical therapists, and occupational therapists are also having to deal with, which is when they cannot show that their patients are improving. It's sort of this whole blanket, oh, therapy doesn't work. I don't think that's true. I think all of us have to be able to say, well, the therapy hasn't worked so far because either A, they haven't received enough dosage or enough intensity of that therapy, or B, we haven't tried that right approach for that person. Maybe there's something else that's going to work for them. And this is not specific to our field, but as I said, this is the discussion in all of rehabilitation. But I really feel like that is what we should be teaching our students to spend their time, is figuring out what works for their patient and going after that.
And
Yeah, and I'd add a
particularly,
C.
oh, go ahead.
I'd add a C to Swati's list there. Maybe C is the skills, ability, and art of that clinician, because it's not that we can just manualize all treatment and here, do this, do this, do this. It matters what you bring to the room as a clinician and what you bring to the person. And that is so huge and so hard to encapsulate.
Reading the room, if you will. Yeah.
Really, and
So,
that therapeutic relationship, that rapport is so important to really know the person and know what their needs are.
Yeah.
Right, right.
well, and this is probably one of my favorite things to ask too, because I love a good case study. So I kind of want to target this in maybe a different way, because when we present our research and our talks we do at different state conferences and other conferences, we tend to talk about the case studies that worked, right? We give these good outcomes and this good stories. But Dr. Kiran, do you have any case studies that maybe something you were trying or your student clinician was doing that it didn't work? What was it and
I
what
prepared an
happened?
answer for this because I read through the questions. And so I actually have two I'd like to talk about. The first one was when I was a graduate student at Northwestern University. I was still in my master's program at that point, and we had a patient who had phonological dyslexia, which is not being able to read certain kinds of words. And I remember my mentor said, "Why don't you run some tests through reading tests through this person, have him read real words, have him read non-words." And it was just the process of testing him through reading and spelling different kinds of words was just unbelievably illuminating, because we could finally distill his problem down to his inability to read non-words. And the reason he couldn't do it was because he couldn't come up with the sound for each font, for each grapheme. Like, he just couldn't convert that. And based on that, we designed a therapy protocol, because she said, well, now you know what the problem is. Why don't you try to develop something that will help him? So that was life-changing for me, because that sort of led me to think about the rest of the treatment research and working with the patient on a daily basis during the therapy session. I learned something every day. So that was, and that's how I teach my students also, to listen to the patient, watch the data every day and see what's working and what's not. That's one story. The other thing that I thought that I learned a lot from is this is when we had initially developed constant therapy. We were doing a clinical trial, and one of the patients finished the study and went home to Maine. And even though he was supposed to participate in the constant therapy study for 10 weeks, kept practicing it at home. And one day the wife called me and she said, I think something is off with X. He's just not able to do the same level of therapy practice because he was doing it every day. And so I started watching his performance on the app, and I realized that he was actually getting works on a daily basis. And she wasn't lying to me, that she was absolutely right in saying that the task he could do a week ago, he couldn't do today. He was slower, he was less accurate. And so I started watching the data for about 3 days. And the fourth day, I said, you know what, I think you need to go to a neurologist because this is really surprising even to me. And it turns out the day she went to the neurologist, he had a stroke the day before. And so that sort of taught me the power of monitoring. And we're doing that with our heart rate, we're doing that with our sleep. It sort of got me inspired to do something about monitoring our brain health, because there is a way for us to track this. And the astute clinician knows what's wrong, but we haven't quite, figured that piece out yet.
Yeah, and that was the piece I was going to mention earlier, was that so many times our patients have other comorbidities and medical challenges that maybe pop up and they have an event of some sort, whether it's a hypoglycemic event or, some heart arrhythmia that's new to them, like AFib, for example. And we see that. So I'm so glad you mentioned that. Dr. Hallowell, what about you? Do you have a case study that maybe wasn't your best moment or maybe a great learning experience?
Oh, that just, Audrey Holland, the great Audrey Holland, one of the pillars of the field of clinical physiology, and I were writing a paper when she unfortunately died, and collecting stories from clinicians about bad things we did, mistakes we made, things we shouldn't have done. I wasn't planning on sharing with you about those today. I'd say early in my graduate school days, I did very clinician-directed goal planning, as many of us were taught to do, that we know best, we're the experts, so we make the goals and we set what are the criteria for meeting goals. And I had a guy who with aphasia who was having a lot of difficulty reading, and so we worked for a couple of weeks on reading. And I said, I just don't think that we're getting anywhere with this. And he said, well, hell, I never could read. So, yeah. So I carry that
Love that.
story with me. Yeah, I'd say I do some expert witnessing of people with aphasia and other neurogenic communication challenges, and I've seen some really sad stories of people doing assessments that don't really reflect the strengths of a person, and I've seen kind of the darker side of families or others who are trying to exacerbate or exaggerate a person's weaknesses largely for material financial control or decision-making control. So those are some of the maybe harder, more gut-wrenching things I've seen. But I've, seen such amazing life turnaround really for so many people. I think of a person who was the president of a nonprofit foundation who had a stroke, had severe aphasia, and everybody just was so gave up, just, oh, he can't do this, he can't do that. His family wanted to just keep him contained at home. Don't, they were afraid something would happen to him if he went out on his own. So his life got very small very quickly. And through a lot of education and counseling with the family and friends and working with the board, the nonprofit board, we were able to have him, collectively with a lot of teamwork, get back to being the president of the board. And that was a really exciting scenario because it involved so many people really changing how they saw what was going on. And first and foremost, him.
Well, that's a great
Yeah,
story.
similarly, there's so much work coming out of the University of Sydney with Dr. Leanne Torr's team and Dr. Liz Brunner That whole, and I know that's modeled more for our acquired brain injury patients, but the push for people to be able to remain on social media, I think, is a big thing. Because say you have a 35-year-old who has a stroke and they've been on social media their whole life. Now they have a communication challenge, and the first thing their family does is take their phone on their computer and say it's not safe for you, versus teaching them how to be safe. So I think some of those things that are coming out research wise too are really good. Are there other research initiatives similar to that that either of you are involved in or want to see kind of expand for our future? That's more like
So
real life stuff.
one of the things we run, one of the programs we run at Boston University, the Center for Brain Recovery, that I'm really proud of is our intensive cognitive communication rehabilitation program. And this is for young adults between the ages of 18 and 35 who have had some sort of a brain injury. Most often it's a car accident, but most often it's also a stroke or a tumor. And, one by one, over the last 6, 7 years, we've been working with each and every one of them to return back to college. And we just give them the starting point, which is all the therapy. We help them develop their goals. We help them identify which college they think they can go back to. We provide them all the counseling and assistance they need to prepare for the college application. We help them decide when they get into the college, what sort of ramp they're going to need, what sort of additional support they're going to need. We work with the Student Disability Office. And really, it's just one person at a time, but it's one person who's going back to college and succeeding. And we're very, very proud of that, because when they finally graduate and we see them back in the workforce, it's just really an amazing process and journey.
Dr. Hallowell, how about you? Any future research that you'd like to see continue that's more of a maybe social-based model or social-based approach?
Well, yes, actually, I've personally gotten involved with research on using applied improvisation with people with aphasia, which is a really very social approach, and it's really fun. And what we can do with the applying principles of improvisation is we can use a lot of evidence-based techniques and then change the context to situations where there isn't necessarily a need to be correct or accurate, where the engagement, the participation is really what's important. And we do that through a series of games or different kinds of theatrical processes. And this is all new to me in the last 10 years. I'm not a person who I ever would have imagined doing improvisation, but now I'm totally into it. And there's so many great people doing this with all people with all different kinds of challenges and disabilities, and more in our field. And I've been blessed to get to work with a lot of different people trying some of these different improvisational techniques blended with other more traditional methods that we use as speech language pathologists. And
That
yeah,
is so
that's fun.
exciting. Is that through your clinic, or is that through an improv center, or how does
Through
this, or a
many things.
collaboration?
Yes, there are many, many facets going on. I personally have done it in several different group contexts, mostly through aphasia recovery connections, through different in-person programs for people with aphasia, and then also with virtual connections for aphasia, which is now going under transformation, so changing its name, but the virtual connections for aphasia, which has been a collaboration between Aphasia Recovery Connection and Lingraphica. We have about 8,000 people with aphasia, I think, that are actually enrolled in virtual connections, and it started in COVID, but now it's worldwide, and we have people from many countries participating, 3 or 4 sessions a day, every day of the week. And that's really enabled so much more of people empowering one another, even sessions that are run by people with aphasia for people with aphasia. I think it's really been transformative to see what can happen now that so many people have been empowered to influence and support one another.
Thank you. Renee, did you have anything else you wanted to add?
Um, Well, there was a question about advice for future clinicians.
Oh, yeah.
Um,
Yes. I didn't know if you had anything with, okay. So you both teach future clinicians, but if, now we have a worldwide audience. So think of some of what you like to teach in your classroom. What would you like to teach future clinicians or clinicians, early clinicians? Any advice? Dr. Hallowell, want to go first?
Well, this is such a big question in my life. It's what led me to write this textbook that I have, which is focused on what is clinical excellence. So it's all about aphasia and the neuroscience, the science, the research behind aphasia, all the scholarly aspects of aphasia. But it really, the focus of all of it is what are you going to do to be a really excellent clinician? It takes way more than just knowing a lot. So what more do you need to do? How can you develop as a person, as a clinician, as a scholar, and in all these different areas to be the best person who can work with a person with aphasia? And I think that's to me a really, really exciting, motivating aspect of that. I think a lot of times with students, they get hung up in how difficult things are, or get worried about how the volume of stuff. You can't encapsulate so much of this content, even just if aphasia in one course in college, let alone some people have to do traumatic brain injury, aphasia, dementia all in a course. It's really unfathomable. So students get easily overwhelmed with the content, and with that comes a lot of anxiety about knowing things and about test scores and doing well in classes and grades. And I think there I really feel for students, and my mantra is always be a vehicle, let it go through you. It's not about you, it's not about your performance. Of course, you need to do well and you need to learn and be a team, but if you get a B, is that going to make you the worst clinician? And I just encourage people to think about, who do you want walking in the room after you've had a stroke? What do you want them to be like? And are you going to care about their GRE score? Or are you going to care a lot? What is it that you're going to care about? And how is that going to impact what you become as a clinician? So
Yeah,
I think it's keep that in mind, and not all the little nitty-gritty things you have to do to get there.
I was just going to say that is what I tell all my students and anyone who's willing to listen, is that at the end of the day, just learn to listen to your patient and listen to them. Like, just have them tell you what's on their mind, what they're worried about, what's affecting them, because all the education will come through. You'll get the foundation, you'll get the practice. But if you don't know how to listen to the patient, I don't think you know how to help them. I try to tell them that every day. I think that's the most important thing.
And Mary Beth, we're starting to get a lot of questions. Do you want me to begin to address those since we have a little less than 10 minutes or so?
Yes, let's go ahead. Let's go
So
ahead and address those. So we haven't come to our full hour because we did start at 3 minutes after. So yeah, let's go ahead and start to address them. But I just want to comment, excellent advice. So be a vehicle, be the person that you would like to see at the other end of that bed. And it's not all about what a lot of what you're saying is it's about what's in your heart as a clinician. And
yeah.
what's in your heart will help you get what's in your head, right?
Yeah, I don't mean to diminish at all what you need to know, because you really do need to know a lot, and you need to,
No, neither do I.
and you need to pronounce your terms correctly, and there is a lot to know, and there is a lot of theory, and it is very important, not to diminish that, but there's way more than that.
And what's that saying? There's, people remember not what you said, but how you made them feel. Right.
Mm.
And I
So
think
true,
that comes
Renee.
across for us quite a bit, because we could say it in the most robotic way and unfeeling and maybe not compassionate. And the person's not going to remember what you said. They're going to remember that you felt cold and you felt disconnected. At least that's been my
And
experience.
and I've heard this said to me a couple of times, but I think it's an amazing phrase, which is doctors can fix the brain in our case, but speech pathologists heal the person. And I think we have to remember that that's our role.
Yeah. So we had a question from Liz that's kind of a two-part. Do you have a good resource going back to applied improvisation? Do you have a good resource to learn more about that? I think you talked about that, but I think she was looking for maybe something a little more concrete.
I could give you some resources in the show notes. I'm actually writing a manuscript on that right now.
Oh, cool.
So there will be something coming out about it. But I would be happy to share some resources in the show notes.
Well, thank you. And as soon as you said virtual connections, I was like, yes, I know I've seen improv somewhere. So I have seen those classes offered on virtual connections. So if you can't wait for the show notes, go to virtual connections.
Well, I'm the one who runs those on virtual connections. So if somebody, it would be possible for somebody to join me in a session if there's something of really interest. So I welcome if you're a person who's keen on improv, feel free to be in touch with me.
Thank you.
In the second part, she asked or mentioned, and I agree with this wholeheartedly, having come from the big health system. Patients really need support groups and aphasia conversation groups, but there's so many barriers to creating those, mainly insurance not covering, therefore, no money and accessibility. Any thoughts on those?
Oh, well, I mean, we live in our healthcare system has real challenges with equity and distribution of resources, and that's within this country. But even if you look across the world, we have most of the world's population of people with aphasia do not get any services.
Yeah.
Right. So it's a real serious challenge to think about healthcare access and equity.
And
Locally
I think that
globally.
groups like the Aphasia Resource Connection and the National Aphasia Association, the fact that they hold all these groups virtually and they're free to access, I think this is something that doesn't exist in many other fields, but you've got these caregivers, stroke survivor, ground grassroots operations that are really helping with the accessibility. It's not the best, but it's at least a start.
Yeah.
So true.
And then switching gears back to implementation science, Jill asked, are there sources you could recommend for staying up to date on science-backed implementation information? I'm returning to a role as a treating SLP in this arena after quite some time away, and I'm finding myself uncertain about which of the wealth of resources available are actually providing the most current and accurate information.
You have me stumped on a book that just came out recently about implementation science within our field. There's a lot of work going on at ASHA and things, but I'm so sorry I can't. Again, we could add these to the show notes. A name to look out for is Natalie Douglas, who's been real serious, an amazing pioneer in translational work and in implementation science. And she's a phenomenal spark plug of an advocate in speech language pathology. And she's well known in other healthcare circles too for all of her work. So definitely check out Natalie Douglas' work.
Yeah, and recently moved down to Louisiana from Michigan. She's a friend, lovely, lovely person. Then we have another question about the program at Boston University for students. Is this a live-in residential program? University of Michigan, where I attended years ago, had one, so I'm wondering what may be available today. And thank you so much for this webinar. It's been great and so informative. Thank you for that comment.
Thank you, Patty.
Before you answer that, Dr. Swathi, or Dr. Kiran, we are right up on the hour. So if you need to leave, please complete all the course modules on your Speech Therapy PD account. And again, as a reminder, this episode is available for 0.1 ASHA CEUs. So
my answer was going to be very simple. Our program is completely virtual, so you can just look us up, Boston University Center for Brain Recovery, and all the information is there, and it's a virtual program.
And I do have a follow-up question on that. So the virtual program, would they then be enrolled in Boston University, or do they go through your program and they could enroll in any university?
they could enroll in any university. Our program is really a rehabilitation program, kind of like the University of Michigan, except it's very specialized and targeted for young adults. So it's a lot of college courses. We teach fake courses. We teach how to take rehabilitation for how to take exams, keeping assignments. It's mostly cognitive rehabilitation that we work on.
Excellent. Thank you. Okay, well, we have a few more questions that, Renee, you want to ask the next question? And for anyone who needs to leave, you can go ahead and leave now, but if you can stay and ask questions, we have a few minutes.
Yeah, actually, the one about Boston University was the last one. That the questions are more about where the show notes will be. So if you know the answer to that, or maybe Yumi can answer for us. I think
Okay.
that the show notes are typically embedded in the module once they're submitted. So Dr. Hallowell and Dr. Kiran, within the next couple of days. I mean, we're not going to be like, you have to have them tonight.
Okay. On my screen, I just saw 7 new messages. So yes, those now that I scroll down, I see they were all related to the show notes, etc. All right then. So if we don't have any other questions, is there anything else that either of you would like to add?
What a pleasure to chat with all of you. And thank you for the questions. Those were really great questions.
Yeah, it's been really, really great and nice to share this with all of you. Thank you.
Yeah.
Well,
Thank you both.
Thank you, Renee. Thank you, Dr. Hallowell. Thank you, Dr. Kiran. This was really such an honor. We appreciate all that you have done for people with neurogenic communication disorders, as well as what you have done, contributed to our field.
Same.
Thank you.
Thank you. Thank you.
And hope to
All
see you
right.
both at ASHA.
Yep.